So, good evening and a warm welcome to all the dignitaries present here. Myself, Rupsha from Learnit, assigned as a session assistant to ensure a seamless experience. Learnit stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for doctors. It is with great pride that Learnit is a digital partner of this event organized by Indian Society for Prenatal Diagnosis and Therapy. And the topic of today's session is a webinar on MTP, Untangling Dilemmas. So let's begin today's session, for which I would like to invite Dr. Bhavna ma'am. So just allow me a moment to share her CV. I hope my screen is visible. So ma'am is associated as consultant at Javitri Hospital and Infertility Center as an infertility specialist. And now I would like to invite Dr. Bhavya Doshi Jain ma'am. Ma'am has completed MBBS, MS, DNB, and she is the consultant gynecologist at Apple Hospital, Indore. So please, ma'am, take over.
Hi, thank you. Am I audible?
Yes, ma'am, you're audible.
Yeah. Can we get a next slide, please?
Yeah, sure.
Yes. Good evening, everybody. Thank you all for joining us today on the topic on MTP. We will be headed by our esteemed president, Dr. Saurabh Dani, sir. He's a consultant OBGYN and he's the president of our ISPAT. He's coordinator of strategic leads and development, Everhill for Comprehensive Women and Childcare. He has been a past president of Association of Fellow Gynacs in Mumbai, and currently he's a coordinator of MCGM Newborn Screening Program. Saurabh Dani, sir, because he's unavailable, he's traveling. We'll be playing his message.
Hello everyone. As you are well aware by now, Indian Society for Prenatal Diagnosis and Therapy, fondly called as ISPAT, is a heterogeneous organization consisting of healthcare professionals from various segments. There is obstetrician and gynecologists, neonatologists, pediatricians, fetal medicine specialists, radiologists, pediatric surgeons, biochemists, geneticists, genetic counselors, and a few more. The aim of ISPAT is to create and stimulate thought on birth defects of genetic and non-genetic origin, how to screen, how to diagnose, and how to manage them. Such a Herculean task is impossible without the involvement of all the learned healthcare professionals. I also would like to take this opportunity and request you to consider becoming an ISPAT member. Becoming an ISPATian is just a click away. Just visit the ISPAT website, ispat.org.in, and click on the tab Join ISPAT. Today we are discussing on medical termination of pregnancy. And it is my pleasure that our budding gynecologist, Dr. Lavanya from Lucknow, Dr. Bhavya Doshi from Indore, have taken the pleasant task of being the conveners for today's webinar under the able guidance of our secretary, Dr. Manjeet Mehta. I wish the moderators and the panelists the very best for today's webinar and would ask all the faculty and delegates to keep the discussion interactive. Thank you.
Can you share the next slide, please?
Yes, ma'am.
Yes. Good evening, everyone. Introducing our secretary now, Dr. Manjeet ma'am. Yeah. Dr. Manjeet Mehta ma'am, she is reproductive geneticist. She is Honorary Secretary General, ISPAT from 2023 to 2025. She has overall experience of 32 years in genetics in India, UK and USA, and she has PhD in human genetics from Jaslok Hospital, Mumbai. She has 2 postdoctoral fellowships from Toronto and London, and she has advanced training in human genetics, Yale Center of Advanced Genomics. She is Director, Clinical Genomics at Live Genogenomics Lab, Mumbai, active member at SR, IAMG, ISHG, IFS, and SFM. She has special interest in genetic basis of disease, gene expression, and she has multiple publications in peer-reviewed journals and book chapters. I request Dr. Manjeet ma'am to say a few introductory words. Yes, ma'am.
Thank you very much, Dr. Lavanya, for that. On behalf of ISPAT, I welcome you all to this amazing topic that is a hot topic of today. There have been so many changes in the MTP Act. There are so many gray areas. We are trying to bring them all to you. We've got the best of experts in the respective fields, handpicked from across the country to bring all these deliberations to you. I would also like to once again touch upon a couple of points that our president sir has said. ISPAT, you all would be knowing, has been around for the last 35 odd years. But today we are reaching across the country. I urge you all to become ISPAT members. Visit the ISPAT website. There are a lot of academic activities that are happening. And we have a laundry list of cities where we are yet to reach out because we're taking prenatal diagnosis, fetal medicine, and genetics to each and every corner of our country. So do visit the website. If your city is on the list, we would be happy to come to your city and conduct a CME for you. Looking forward to a very interesting and interactive webinar with really academic good deliberations. Once again, welcome to all of you. Thank you.
Thank you, ma'am. Can you please share the moderator slide? Yeah, Dr. Lavanya.
Yeah, I would like to welcome Dr. Pratima Radhakrishnan, ma'am. She is Director of Bangalore Fetal Medicine Center and FGI Fetal Care Units. She is Director of FGI Research and Training Institute. She is Diploma in Fetal Medicine and she is Diploma in Advanced Ultrasound. She has been awarded with multiple orations and multiple awards. Thank you, ma'am. Thank you for joining us today and helping us in organizing such a nice MTP program, ma'am.
Can you move the next slide?
Next is Dr. Richa, ma'am. She is Director Professor OBGY, University College of Medical Sciences, GTB Hospital, Delhi. She is the Foxy MTP Committee Chairperson. She is National Corresponding Editor Journal of Obgyn of 2021 to 2024. She is an IAG Managing Committee member, Joint Secretary of IAG Delhi Chapter, and she's Organizing Secretary of International Hysteroscopy Congress and Organizing Chairperson of AOGD Pre-Congress Endoscopy Live Workshop. She is a member of Scientific Committee of Global Congress on Hysteroscopy. She has also been awarded with multiple awards and prizes, and she's been editor of 2 books on hysteroscopy. Thank you, Richa ma'am. Thank you for co-moderating this program with Pratima ma'am.
Thank you, Dr. Lavanya and Dr. Bhavya, and Dr. Manjeet, of course, and Dr. Saurabh Dani for having us put up this show. Thank you.
Thank you. Dr. Bhavya, I would request you to please announce our panelists.
Yes, sir. Can you share the panelist slide? Pratima ma'am, Richa ma'am, shall we introduce the panelist?
Yes, please.
Okay. So introducing our first panelist, Dr. Anthony Robert Charles, sir. He's MCH Pediatric Surgery, FIAPS, MRCS, and MS. He's Director at Kinder Surge, Consultant Pediatric Surgeon at Rainbow Children's Hospital, Manipal Hospitals, Motherhood Home, and St. Philomenos. He has special interest in medical ethics, neonatal surgery, minimal invasive procedure, pediatric urology, and school education. And he's also Secretary at Pediatric Endoscopic Surgeons of India. Thank you, sir, for joining us today for this interesting session. Can you move to the next slide? Yeah, introducing Dr. Chaitanya Datar, sir. He is consultant clinical and metabolic geneticist. He is director at Sujanand Clinics, Pune, Mumbai, Nasik, Solapur. He's also associated with Bharati Vidyapeeth Medical College and Hospital, Pune, KM Hospital, Surya Mother and Child Hospital, Pune. He has 14 years of experience in this field and he's in charge of fellowship program in genetics and metabolics at Bharati Hospital. He has multiple publications, over 30 plus in national and international journals, 4 book chapters, and he has multiple professional achievements, including position of Joint Secretary, Indian Society for Inborn of Metabolism, and chairperson genetics subchapter IAP Pune. His areas of interest are dysmorphology and phenotyping, fetal autopsy, and prenatal diagnosis and reproductive genetics. Thank you, sir, for joining us today. Moving to the next slide. Ma'am, Lavanya, ma'am.
Yeah. Next is Dr. Indranil Dutta, sir. He's MBBS, MS, and PG in hospital management. He has also done his medical law. He has an advanced laparoscopy surgery diploma from Germany, a diploma of cosmetic gynecology from American Aesthetic Association. He is into fetal USG and endosurgery and infertility. He has a fellowship in gynae-oncology and is trained in IVF and ICSI and embryology. He is currently the professor and unit head in the Department of OBGYN at IQCMC, Durgapur, West Bengal, and he is director and senior consultant of nursing home in Kalyani. He is the director of Precision Health Services. He has published more than 50 articles and he is an editor in Foxy. He has organized 6 Foxy conferences and he is a member of Foxy IMA and SAFOG. Next, please. Dr. Kuldeep sir, he is a master trainer in ultrasound. He is practicing USG in New Delhi and is known for his skills in OBGYN and infertility ultrasound. He has delivered more than 600 talks in national and international platforms, and he has shared his academic experiences in Japan, France, and many other countries. He has received multiple awards and gold medals in the field of ultrasound. He has authored more than 16 books on USG in Gynax and OBS. His books have been translated into various languages, and he is currently running a successful Sono school in which he organizes various training programs in ultrasound. Next, please.
Next slide, please. Introducing Dr. Milind R. Shah, sir. He's President ISOPAP, member of Maternal and Fetal Medicine Committee, President IMA, Chairman Safe Motherhood Committee, Founder President of IHRF, Honorary Secretary, Federation of Asia, Oceania Parental Societies, and Vice President of Foxy in 2011. Sir has novel maternity and nursing home, an endoscopy and infertility center in Solapur. And sir has authored a book, Hypertensive Disorders in Pregnancy, Pelvic Organ Prolapse, and contributed more than 20 chapters in various books. And he has published in many national and international scientific papers in various research journals. Thank you, sir, for joining us. Moving to the next slide. Introducing Professor Dr. Narendra Malhotra, sir. He's MBBS, MD, FIA-GO, FICMU, FICOG, FICMCH, FRCOG, FICS, FMAS, FIAPM, and FICRM. He's Managing Director at Global Rainbow Healthcare Hospital, Director ART Rainbow IVF, Director Foxy Smriti Manyata CSE, Vice President of the Society of Ovarian Rejuvenation. Sir has multiple chapters, published multiple papers, has given multiple orations. Thank you so much, sir, for joining us today. Sir has, okay. Yeah.
Dr. Seetha Ramamurthy, ma'am. She is a consultant of fetal medicine on OBS, Apollo Multi-Speciality Hospital in Kolkata. She is honorary treasurer in Bengal OBS and Gynae Society. She is chairperson of Genetics and Fetal Medicine Committee. She is president of Society of Fetal Medicine Kolkata chapter, and she's a fellow representative of AICC RCOG Eastern Zone. She is joint secretary of ISOPAP Kolkata chapter. She is an MRCOG Part 3 examiner and faculty. She's a member of National Board of Specialist Committee of Maternal and Fetal Medicine. She's a peer reviewer of Jogi and Journal of Fetal Medicine. She's also a faculty trainer of Foxy recognized training centers. Next, please. And Dr. Nikhil Datar, sir. He is a consultant gynecologist in Medical Director, Cloud9 Hospitals and Yashoda Hospitals of Mumbai. He is currently a visiting professor in Maharashtra National Law University. His judicial activism has paved way for amendment of the MTP Acts. He has received multiple awards, the Commonwealth Austrian American Foundation Fellowship Award, MM Hane Vatan. Dr. Nikhil sir is not currently here with us. He'll be joining later at around 7 p.m. Thank you all. Thank you, faculty. Can we have Pratima ma'am and Richa ma'am starting with the sessions?
Yeah.
So thank you, Dr. Lavanya. So thank you, Ispat, for giving us the opportunity. And thank you, Dr. Saurabh, Dr. Manjeet, and the organizing team, Dr. Bhavya and Dr. Lavanya. Thank you so much. And I welcome all the esteemed panelists along with my moderator, Dr. Pratima. So welcome Dr. Anthony, Dr. Milind Shah, Dr. Kuldeep Singh, and Dr. Narendra sir has joined. Welcome, sir. And Dr. Indranil. So welcome you all. And I think Dr. Nikhil Datar will be joining shortly. And Dr. Seetha also, she'll be joining shortly. So regarding the flow of this panel, I will just, in one or two slides, I will just give a brief overview of MTP Act. And then we will go to, since our panel is focused on congenital anomalies and MTP. So we will take up one case and then we will discuss about the diagnosis of the case. And then we will discuss about the MTP related queries about the case. So total 9 cases we are planning to discuss today. So I will just share the screen. And my regards to all the respected seniors and colleagues who have joined today. Okay, so is my slide visible now?
Yes, ma'am.
Okay. So once again, a very good evening, everybody. And I bring greetings from UCMS and GTB Hospital, Delhi, and from Foxy MTP Committee. So now we all know MTP Act, it was enacted in 1971. And now we are with the new recent amendments, that is 2021. But it is a great achievement. But the journey was quite long. As we all know, that bill has to be first passed from both the houses and have to get the consent of president to become the act or the law. And then the state has to formulate the regulations and the rules how to implement that act or the law. So this was quite a long journey. As you can see, Cabinet has approved in January 2020, and then it was introduced in Lok Sabha, passed from it, and then Rajya Sabha passed from it. So finally, the MTP Act amendment was published in the Gazette on 25th March 2021, and then implemented on 24th September, and finally it was notified on 12th October. So now we are with the new MTP Act. Now, this amendment actually, it has given a lot of facilities for the women empowerment, and as well as it has strengthened our peripheral doctors also, medical doctors also. We have given them the power to do the MTP, which we will be discussing in the due course. Now, coming to the now MTP Act, we have to remember it is just 4 things: who, when, where, and documentation. Who should do the MTP? We have to know what are the indications, then the place where we can do the MTP, and the paperwork. So these are the most important 4 things which we have to follow. Why? Because MTP is the act, and if we contravene the act, we are liable for some kind of punishments, which again we will be discussing in the due course. Now, there are the 4 main amendments which has taken place. Now, first was the gestational upper limit. Now, gestational upper limit, it is increased to 24 weeks in the certain category of the women, and beyond 24 weeks for the fetal congenital anomalies. Now, that means fetal malformations or congenital anomalies, they are entitled for MTP at any period of gestation, and there is no upper limit. Now, next is the contraceptive failure part, which was applicable to married women earlier. Now, this indication is applicable to unmarried women also. And now there is a ease also with regard to the opinion, because before we do the MTP, the opinion also, a form has to be signed. So now if we want to do the MTP till 20 weeks, one registered medical practitioner opinion is fine. 20 to 24 weeks MTP, 2 RMP's opinion is fine. And beyond that, medical board approval has to be taken. And that is applicable only for the congenital anomaly cases and no other cases, which again we will be discussing in the due course. Most important thing is the confidentiality part. Now, earlier there was only 1,000 rupees fine, but now we have fine as well as imprisonment of 1 year. So confidentiality has to be maintained. Your documents and paperwork has to be in place to be medico-legally safe. Now, this is a very, very important slide, which I was just telling, the contraceptive failure, which was applicable to married women. Now it applies to unmarried women also. And then up to 20 weeks, there are only 5 indications which are for MTP. That is to save the life of mother, to prevent the grave physical or mental injury to the mother, then congenital anomalies in the baby, alleged rape, and contraception failure. Now, upper limit is increased for 7 categories of the women only. Those are survivors of sexual assault, rape, incest, minors. Then if the woman has become widow or divorced, and if she has a physical disabilities or mental illness, including retardation and fetal congenital anomalies. Now, fetal congenital anomalies can be incompatible or there can be a risk. It doesn't say it has to be proved. So if there's a risk that the baby will be born with physical or a mental handicap, so that anomalies are also taken into consideration. Unmarried women are also included in this category, 20 to 24 weeks MTP. And then last is the humanitarian ground. Now, most important, we have to remember fetal congenital anomalies. They are entitled for MTP at any period of gestation up to and beyond 24 weeks. And there is no gestational upper limit for that. It is left to the medical board discretion. Now, this FOXY ICOG GCPR we had formulated keeping in mind the new MTP Act amendments, and this was released also. So in this GCPR, Dr. Nikhil Datar was also a part of this GCPR. So in this case, in this GCPR, we have listed all the anomalies as per the document of 2017, Government of India, Department of Health and Family Welfare, Ministry of Health. So CNS anomalies, cardiovascular anomalies, there is a long list which we try to enumerate everything, including musculoskeletal, dermatological and abnormalities. But still, this list cannot be considered as complete. And I request everybody, all the obstetrician, whenever you get any case of congenital anomalies, please have an opinion of your fellow colleagues, other specialists like fetal medicine specialist or neonatologist or the neurosurgeon, depending upon the cases which you are dealing with. So now with this as a small background, now we will take up cases one by one. Then we will have a discussion about the diagnosis and then the MTP part. So I will stop my screen share, and Dr. Pratima, you can start your screen sharing. And I request everybody to keep posting your questions in the chat box. And we will try to answer the questions in the chat box itself so as to save the time. And if there is any question which requires elaborate discussion, so we can take up as we are doing the panel. So over to you, Dr. Pratima.
Okay. So I presume my video is visible and you can hear me. So thank you very much. Welcome to the panelists. So without wasting much time, I will just move on with the first case. And so this is a 32-year-old, one previous miscarriage, and she was referred to us at 13 weeks with increased nuchal translucency and omphalocele. As you can see, there is indeed increased nuchal translucency, and there's quite a reasonable size omphalocele there. There was a midline anti-abdominal defect, and it contained only the bowel, and there was this membrane covering the bowel. So it was clear-cut omphalocele. So my question is going to start with you, Dr. Kuldeep. If you could just kindly, say how would you manage this further? We made a diagnosis. She's referred increased nuchal translucency and exomphalos. So what would you tell this woman next at 13 weeks? Dr. Kuldeep, can you unmute yourself?
Yeah, I've unmuted. Am I audible now?
Yes, you are. Thank you.
So the moment we're looking at a thick nuchal translucency, that's definitely going to have an index of suspicion that we're looking at some sort of an aneuploidy, and it's quite a thick NT. We need to know what the exact measurements are. And the moment it's a thick NT, along with it, there's an abnormality, especially an abnormality like an omphalocele. Again, we've seen that it is covered with the membrane. There is the umbilical cord inserting on top. So we're sure about it that, yes, it is an omphalocele.
So what would you do next? I mean,
it's not a parasagittal abnormality. We are going to be thinking of, yes, there is a definite problem over here, and we need to be ruling out that. But in terms of as an ultrasound person, I would definitely be looking at the other features in terms of any associated abnormalities.
Nothing else.
I looking at, if there wasn't anything else, then
these are the two main findings,
so we definitely going to be thinking of, yes, what are the other factors? Has a dual test already been done, which obviously wasn't being done because it's always done after the nuchal translucency has been measured. We're going to do a combined testing, and
we had an increased nuchal translucency, we have a fetal abnormality. So I would just straight away do an invasive procedure for
Absolutely, absolutely, because
nuchal
we
was
need to figure out.
4.2. Yeah, 4.2.
So that's definitely more than
There is no
3.5.
point wasting time doing serum markers in this particular case.
Absolutely, absolutely. That's what the point is, that there is no point doing a serum marker the moment you're looking at such a thick NT, and along with it, you're looking at an associated abnormality as well.
And no role for NIPT as well.
Definitely not, because
Definitely
that's
no
again
role,
going to be
because it's a
screening.
screening test. Yeah,
Absolutely.
So, well, we do the invasive test, and I'm sure Dr. Chaitanya will come in with his inputs on the number of genetic syndromes. So, for example, for a moment, if we think that the chromosomes has been done, that CMA has been done, and it's all normal, so then exomphalos and nuchal translucency is resolving. So we rescan after at 16 weeks, and now we say, okay, there is only an exomphalos there. So is that a treatable condition? Dr. Anthony, he's a pediatric surgeon in this group. So your inputs on the operability of exomphalos, and what are you looking at exactly to be able to tell the couple? Thank you.
Yeah. So the first thing is, as both of you have mentioned, is my biggest fear before I start counseling a pregnant mother with an exomphalos condition is the associated anomalies, and the outcome vastly depends on that. So at an early stage like this, I would still be very guarded in my counseling to them. I tell them that about half of them we are able to give a really good result if they have no other associated anomalies. I think that's the basic message, but we'd still follow this. And the cardiac anomalies also, I'd be very interested to go along as the pregnancy progresses, because that's the other confounding variable for the prognosis. So an isolated exomphalos with a large defect, or what it's called a major exomphalos, then I would still give them a guarded picture of the fact that it may need a staged repair and may not just be a simple.
That looked a fairly large exomphalos on the image.
Yes.
The small exomphalos, the bowel only, this was, although this was only the bowel, but still it was fairly large. And once you've excluded the chromosomal abnormalities, the small exomphalos can be treated well, right? And about 80 to 90% of them will even resolve by 20 weeks. But I think it matters what are the contents of the exomphalos, associated abnormalities, and that's important. So Dr. Chaitanya, so if we do a karyotype, is that enough? Or do we need to do further testing?
It's kind of a picture at, if we have a high NT along with a large exomphalos, we would do a CVS, do a FISH along with a QF-PCR for a quick evaluation for trisomy 18 and 13, because almost about 30 to 50% of these cases would have these common aneuploidies associated. Further on, we would go for ideally for a microarray, because microarray is giving us about 15-20% more information than a karyotype. So in a karyotype, we're just looking at textbooks from outside, while when we're doing a microarray, going to the chapter, sub-chapter level. Ideally, high resolution microarray would be important. And when we are dealing with a case of exomphalos, another test that we need to do is for Beckwith-Wiedemann syndrome.
I was going to ask you that question.
Yeah, 10 to 20% cases of Beckwith-Wiedemann have exomphalos as the only anomaly which can be seen earlier, and they may just proceed, and later on postnatally we will see that a large tongue along with the hypoglycemia and other features.
So pretty much CMA will not exclude Beckwith-Wiedemann syndrome.
Yes.
So we have to go with ultrasound continuously.
So the methylation study is what is done. So we need to do a methylation study for Beckwith-Wiedemann syndrome in case
we have to specifically ask for that, right? We have to specifically ask for these tests, because if we don't ask for it, it will not be covered, and we cannot presume that a karyotype CMA will just sort out the Beckwith-Wiedemann, because Beckwith-Wiedemann also has a guarded prognosis, right?
To some extent, because we do have good survivors. So essentially in the neonatal period, if the antenatal and neonatal period, they do well, then they have a good survival rate.
Okay.
But the only point that we'll pick up Beckwith-Wiedemann antenatally would be an exomphalos.
Okay. Okay. And a large exomphalos.
Large
exomphalos. Yeah. Okay, fine. Thank you very much. So we will move on. I mean, well, as you know, happens with some, I would say many of the patients, they decided to terminate the pregnancy without any further investigation, sadly. So anyway, but coming back to allowing Dr. Richa to share her screen.
Pratima, can I have one actually discussion on this particular part?
He's going to
now see,
Richa, meanwhile, you can share your screen. And also, I'd like to welcome Dr. Seetha. She has just joined the panel. Yeah, thank you, Seetha.
Thank you.
Now,
Thank
see,
you.
as you said very correctly, that quite few of these patients now they want to undergo termination. Rather, they always refuse for the further investigation when they find such two major actually the findings on ultrasound. So I just wanted to ask Nikhil. I think he has joined or no, not yet.
No,
In
Nikhil is
such
going to join only by
cases,
7 o'clock.
it doesn't get fitted in our indications of MTP. So what will be his say on that? Rather, anyone else can answer that.
I think
What will
Dr.
be
Richa is going to cover that, Dr.
Okay, we will. I'll be covering that in due course. Dr. Nikhil also
Yes,
will join.
yes.
So let us
Okay,
start
okay.
with the basics.
Yeah,
So now
yeah,
this
sure.
same case now has been terminated or has decided for MTP. Now a basic question. Now this patient is at 14 weeks gestation. Now anyone can answer who can do the MTP for this patient. Now keeping in mind gestational age. Now can MBBS registered medical practitioner do the MTP, or it has to be the obstetrician gynecologist only who should do the MTP? Who, and opinion is another most important aspect. Who should give the opinion, and whether you will proceed with medical or the surgical termination?
When it is said the termination of pregnancy, when that's registration has been availed, it all depends. Even MBBS doctor, suppose he has gained sufficient experience and is eligible as a RMP, what actually the MTP law defines, he can definitely do that, because according to the law, up to 20 weeks now, only one person can opine. But it's always better to have the opinion of OBGYN, because there is a very thin line between the medical and surgical abortion at 14 weeks. Quite often we find that with medical abortion, there may be sometimes delay or very rarely failure. But now with availability of all those good prostaglandins available with us, medical termination is possible. But what I feel, I think Pratima also can add on that. Once we abort them, it's very essential to do the further testing on the abortus. Quite often, what happens in my practice, now such patients, again, they are reluctant for the further testing. But I always store their DNA, and so that eventually, when they learn little more about their case, they come back saying that yes, it was better we would have done for the further testing, and then those DNAs which are stored can be utilized for the further testing. Yeah.
Okay, so as Dr. Milind sir, you have rightly answered. So obstetrician and gynecologist, they can do MTP for any period of gestation. But as you said, MBBS, RMPs, now we have to be very clear who are the RMPs, registered medical practitioner. Means they have a degree diploma, which is a recognized one, and also they have the registration in the state. So they are RMPs. So if a MBBS doctor, they have a 6 months of house surgery completed or 1 year of experience in obs and gynae. So they are treated equal to the person who has a OBGY degree and diploma. So they can also do the MTP up to and beyond 24 weeks, provided other criteria is met. Now coming to the opinion, again I'm highlighting for less than 20 weeks MTP, one RMP opinion, but that RMP has to fall in the particular category. It is not, suppose if you are going to terminate a pregnancy which is more than 12 weeks and you have a MBBS RMP who has just a 3 months of training in obs and gynae can give the opinion. No. Opinion and the person who does the termination has to be in the different category. They have to fulfill their own category. So up to 24 weeks, we can do the termination by the opinion of the 2 RMPs, and beyond 24 weeks is the medical board who will give the opinion. Now, even if the medical board gives the opinion for MTP after 24 weeks, the 2 obstetricians, they have to do the MTP. That means the 2 obstetricians' name has to go in the register that they have performed MTP. This is after the MTP Act amendments, it has come. Now, regarding whether to do the surgical or a medical method at a 14 weeks period of gestation, you can go for medical or surgical, but dilatation and evacuation, now strictly, we should not be doing in a fetus which is more than 15 weeks of pregnancy. This is as per the Government of India guidelines also and WHO also. So beyond the 15 weeks, we should not be doing dilatation and evacuation, because now we have the wonderful drugs, mifepristone and mesoprostol drugs. But one thing we have to keep in mind that Mifi and Meso drugs, they are not approved by DCGI. But WHO recommends this method as a safest method for second trimester MTPs, and everybody is using it. and we are getting very good results. Now, over to you, Dr. Pratima, for next case. Please unmute yourself.
Sorry, in this particular case, you're saying that it has to be done by, I saw it was in your yellow format where about up to 20 weeks, there has to be a PG diploma or some 6 months experience in an OBG department, right? Or a postgraduate degree in OBG, right? So becomes very important. So we'll move on to the second case.
Yeah, then only they get the permission as a RMP. Unless
it has to be registered centers.
Yes. That we will be talking in the due course.
Okay. So we move on to the next case, where is a consanguineous marriage, second cousins, and the husband had CLAP and he was operated, and in addition he had non-Hodgkin's lymphoma. So the first trimester screening, there was a history, 3 previous terminations. First one was a bilateral cleft lip and palate, along with a questionable spinal defect. It was not evaluated and terminated at 20 weeks. The second one was a spontaneous miscarriage, and the third one, where she was referred to our center, was a bilateral CLAP and a VSD, and she terminated, and the amniocentesis was done elsewhere, and they had done a FISH and a karyotype, which was reported normal. So I'm talking about the 4th pregnancy that she had come back to us in the first trimester. And this were the previous investigations. Dr. Chaitanya, I'd like to bring your attention to this. We had diagnosed it, but they went elsewhere and got the amniocentesis done, and the DNA fortunately was stored. And the tests that were done on that sample, FISH and karyotype, mother's karyotype, and the father had this, extra chromatin, the heterochromatin there, increased length, and no genetic consultation was done.
Right. So what we're finding here is it's a consanguineous family, and there has been a recurrence of the same abnormality in the consecutive pregnancies as such. So usually, 2 pregnancies. So essentially, when we are finding a recurrence of abnormalities, the possibility of a chromosomal issue becomes lesser. We are likely dealing with a single gene condition, and the ideal test in this scenario would have been exome sequencing. So since we have the DNA sample of the 3rd baby available, it would be preferred to consider an whole exome sequencing on the DNA sample so that we have the exact mutation which is diagnosed. You can do it also as a trial. That is, you test the fetus along the G3 DNA along with the parents to get a clearer idea as regards to the segregation of the mutation which we have identified in the 3rd pregnancy. That is the 3rd.
I think the point I would like to highlight here is the DNA is not stored, like forever. Right? DNA, the labs have a policy to store the DNA either for 1 year or 2 years. So whatever genetic consultation and further testing has to be done within that time period itself. Otherwise, you lose that DNA. Right? It's not the quality of DNA, but they can only so much DNA can be made in laboratories.
And the YPH plus actually has no major significance.
This was just the thing. So basically, it was still uninvestigated by the time they came for the NT scan. On the NT scan, again, first trimester, and we had suspicion of CLAP right in the first trimester itself, because we can now look at the maxillary gap, and if you can see my arrow, I'm pointing out to the maxillary gap there, and all the views were abnormal and highly suspicious of a recurrence of cleft lip and palate. Again, cleft palate, cleft lip, and in addition, there was some suspicion on the spine also. Didn't look quite normal and appeared like a close. If you remember the first one, first pregnancy also, there was a question mark on the spinal canal. So Dr. Narendra Malhotra, I think you're there now, right? So how would you manage this now at 13 weeks? 12, 13 weeks. She's come in the first trimester. We have a DNA stored. Unfortunately, they've still kept the DNA. Are you there, Dr. Narendra Malhotra? We cannot hear. Okay, maybe I can get one of the other persons. Seetha, are you there? Seetha, can you take up the question, please? Yeah, unmute yourself, Dr. Seetha.
Yeah. So as Dr. Chaitanya said, here we have the DNA stored. So the next step would be to counsel them, saying that this is possibly a more like a single gene disorder, and go in for an exome. And definitely this baby will also need, but definitely, so either we could do a tryoexome in this baby itself, but knowing the mutation in the previous fetus will definitely help so that we know we have an exact target, test to do. And now she's how many weeks did you say? She's in the first trimester.
First trimester,
Yeah. Yeah, so we'll do a chorionic villus sampling and send it for an whole exome.
Well, it'll be
tryoexome.
4, isn't it? Because we have to go the DNA, the parents, and the fetus.
Yeah, exactly.
It'll be 4. It won't be
So
trio. It'll be trio plus 1.
Plus 1, and that is usually, the cost implications are there, but we have to tell to get a good answer and an early answer. So that rather than finding a needle in a haystack, if we have the other DNA stored, which we have the mutation, it will be easier and faster. But yes, cost implications.
I'm going to go backwards now. I'm going to go backwards to the first pregnancy. Say, for example, this is the first pregnancy. She comes with only cleft lip and palate, right? So now there is an anomaly. The spinal anomaly is still a question mark. Dr. Anthony, how would you like to counsel this couple? We know clap is a correctable anomaly. But how?
I still know that the father had the same.
Yeah, the father had the same thing. Yes.
So I'm guessing the family is already tuned to the anomaly itself. Yeah. So, and with that information of it being a single system, again, just a clap and nothing in the spine. A is the genetic counseling which you people have already would have done in terms of the transmissibility and the associated, the next sibling and all of that. Surgically for the baby, the path for us is very clear. Path is definitely correctable as long as it is come by itself. And the fact that it's a multi-stage repair, we do the lip early and then we do the palate at 1.5 years, maybe something at puberty. So it's very important for me to counsel to them in the antenatal period that it's not a single shot, one-shot operation, but it is definitely not a life-threatening disease. And it's more of an irritant disease. There are stages, minimum of at least 2, may go up to 3 or 4, depending on how the nasal thing and the soft palate also may need to be revised later. So when I give them that true impression, and if they're still motivated, then I think it's a supportive journey from them.
Yeah. I suspect, I mean, it was a bit unusual that the father had the condition and then they terminated the fetus that had the same condition. But I suspect that was primarily because of the doubt that was raised about the spinal problem rather than anything else. So
can I just add in here, Pratima, that you said if it was a first pregnancy and there's nothing else, I mean, no previous history. Did you say that? Did you ask that, or you said?
No, the first pregnancy had a question mark on the spinal. We had not seen the first pregnancy. We had not.
No, what I meant to ask is, did you ask this question that if this was the first pregnancy, would it have been different, the counseling?
Well, yes. I mean, even if it was the first pregnancy, I just wanted to know, basically highlight that it's a correctable condition.
Yeah, right? True. What I wanted to say is we would offer invasive, but call her back at 16 weeks.
The first. Yes.
Yeah. But call her back at 16, that we make sure it is still an isolated and counsel accordingly.
I'm coming to that.
Sorry.
But before that, Chaitanya, I think you've already answered the, all the four have to be done. What is the timeline for these exomes in pregnancy? Because we are really stuck for time here. Well, not so stuck, but yeah, kind of stuck.
So around, say, 3 to 4 weeks is the minimum time that would be required for an exome result to come out. But you can say, usually while counseling, we would say about 4 to 6 weeks on an average that would take for us to get the results.
Is there a specific sequence in which you would like to do this?
Yeah, so here in this case, if the family is affording, I would go for a quadroexome. So that is doing the previous fetus, the current fetus, along with the parents. So that would give us a more clear idea. Sometimes in consanguineous couples with good counseling, you can do a trio wherein you're testing both the fetuses and one of the parents because you're expecting a similar type of a mutation being there in both the parents since it's consanguineous. But I would prefer to do the father here, just to rule out. And the father's, the laterality of the clefting is also very crucial. So whether the father had a more of a unilateral type of a cleft lip palate also sometimes needs to be reviewed occasionally. Sometimes that could have been more of a nutritional cause, and this could have been more genetic in nature. So you review the case in entirety before.
Okay. So I think for a moment, after 4 pregnancy losses, affordability is not an issue for most parents anyway. Right. Affordability is only a question of first pregnancy because it is put into their heads that they terminate, just terminate without thing. But after they have 3, 4, they will make money from anywhere. They will bring the money from anywhere
True.
the test. That's what has been our experience, because then they don't want to waste any more of the woman's health in pregnancies after pregnancy. So basically, that's what happened. We did an amniocentesis, stored the DNA. They went through a termination, and subsequent to the termination, they had further testing and evaluation with our genetics team, and they found the homozygous mutation in the fetus and also the previous DNA, and both the parents were carriers for the MASP1 gene, which was related to the phenotype. Although it said uncertain significance, but both were carriers and it correlated with the phenotype. I think most of us look at a variant of unknown woos and then forget about the phenotype. I think that is very, very dangerous. We have had on and off, we have had occasions where woos has been reported, but it is related to the phenotype. So I think these
That
woos
mostly happens because the current reports that we do, we are using more of Western literature. So in the Indian context, sometimes these same
have to
wounds can
correlate
be
it.
pathogenic or like
Absolutely,
pathogenic in
absolutely. So although they report it as woos, we should not presume the woos is really not, is a benign condition. Here with the phenotypes that was described in the ultrasound, and I think we had postnatal images also, we could actually come to a conclusion this was a pathogenic 3MC syndrome, and that was the postnatal images of that fetus, and of course some homework was done.
Segregate the classification can change over time. Today it is a
Yes.
US, it gets elevated to a likely pathogenic or pathogenic. So we have to reclassify these variants from time to time as well.
Yeah, and I think also very importantly, we all should kind of keep updating ourselves continuously, because what was woos maybe 1 year ago is not woos anymore. It becomes pathogenic within 6 months, right? So don't take woos lightly is the message that I want to give out. So you have anything to add to this, Dr. Richa? I'll stop.
Yeah, please. I'll just share the screen. Okay, so now this case again was offered termination and underwent MTP. So I just want to ask any of the panelists. Now, suppose this patient is at district hospital. Now, do you think we can do the MTP in the district hospital at 8 weeks period of gestation, or she has to be transferred to any tertiary center or medical college? Anybody can answer. As per the MTP Act norms. Dr. Indranil, you are there?
I think you should take the name and ask
Dr.
the
Indranil.
yes.
Yeah. Hello.
Yeah, please.
Yeah, you're audible.
Yeah. See, in district hospital, we can do it, but better preferred is it to transfer to medical college hospital, because of we may require additional support, and mainly what we do in Bengal is we have to take written permission from CMOH office, that is a chief medical officer office. So district hospital is also eligible if he gets permission, the hospital gets permission, and medical college doesn't require the special permission from CMOH office. They can proceed just with information to the medical superintendent of the medical college. That's it. That is what we do in.
Yeah, this is the government we are talking about, government health facilities.
Yeah.
About the approval, we'll talk later. And she's at 18 weeks pregnancy. Now, what are the drugs and the doses you will use to do the MTP? Because doing MTP in second trimester is really very tricky. No doses.
See, actually, what I do is, I am more in support of using the mechanical dilatation method. Initially, before we actually use some medicines, like I use the catheter, Foley's catheter, to just put inside the cervical internal os and dilate the bulb and keep on wait, just so that it dilates to at least 2-3 centimeters, and then we can use the gel, Cerviprem gel or something to put intracervical and or misoprostol, which actually helps.
So all the cases you would like to do the mechanical dilatation first. Anybody, other panelists, what are your experiences? What are your say on this?
Yes. Can I say something, Richa,
Yes,
on
yes,
this?
Dr. Milind. Yes.
When we use the both MIFE and MIZO in such cases, the results are quite good. We give MIFE as usual 48 hours before, and then we give the MIZO 400 micrograms 6 hourly, and many of the patients they abort. What Indranil told was true that many of the colleges still practice the mechanical dilatation. They put the Foley's catheter, which we have seen in many of the colleges. Related to the where it can be done, I think MTP center, which is recognized, that itself is a criteria. It doesn't make any difference whether it is a district hospital, whether it is a tertiary care center for the termination of 18 weeks pregnancy. But of course, if that particular clinician is willing to do that, many of the clinicians at such places or in some of the private sectors have some inhibition for unspoken reasons. So in those cases, the cases can be referred, but otherwise it can be done. Any recognized MTP center, termination can be done.
Okay. And as you said, Dr. Milind sir, you will be using mifepristone and mesoprostol. Now, suppose you have already used 5 doses or the maximum limit, and patient doesn't respond. Then how do you go about it? She's 18 weeks for MTP.
Yes. Suppose she doesn't respond to our medical line of management, then we'll have to think of the mechanical dilatation. Quite often, actually, we put Foley's catheter and we wait, and the pains start. Sometimes we also use the Cerviprime gel, but that is rarely required. Very remote, actually, rare cases we require that. Quite often, they abort well with the Mife-Mizo combination and the putting Foley's catheter.
Okay. So now, as everybody said, now about the place where we can do the MTP, now we have to understand one thing very clearly, that the government hospitals or the government health facilities, they don't have to take any kind of permission or the approval from the government. They are already approved for doing the MTP. But at PSC level, you can do the MTP till 8 weeks. CSC level, you can do till 12 weeks. District hospital up to 24 weeks after the amendment, and a medical college for any period of gestation up to and beyond 24 weeks. But of course, as you all said, it depends upon the decision of the treating doctor also. But this is the entitlement. Now the approval has to be taken from the private hospitals only. Private health facilities, they have to apply for the registration. They have to apply for the approval for MTP, and which is given by the district level committee. Now, regarding coming to the drug regime, now the government of India also has recommended in our Foxy GCPR also we have listed this. So, Mifi combination drugs, they work very beautifully. That is mifepristone 200 milligrams orally. Mifepristone is always a oral drug which we have to give. And after 24 to 48 hours, we have to give the mesoprost dose, that is 800 micrograms if we are doing MTP for less than 12 weeks. And then it can be put pervaginally, sublingual or buccal. Now, and even the letrozole tablet also is now recommended by WHO for doing the MTP up to 12 weeks. So letrozole also, the dose has been defined 10 mg for 3 days, and after 24 to 48 hours is the mifepristone that we have to give, that is 800 micrograms sublingual or pervaginal we have to give. Now, coming to the second trimester MTPs, now the doses are defined by the FIGO also 2023, and WHO also has given the dosings, and GCPR also we have listed. This is a very important table I have just highlighted. So the combination regime mifepristone dose remains the same, 200 milligrams oral, and this is for at any period of gestation when you are doing the MTP. 200 is same, but it is the dose of mesoprost which you have to keep on decreasing. That means till 24 weeks, 400 micrograms you have to use. Then 25 to 28 weeks, you have to use 200 micrograms. And after that is 100 micrograms. And you have to keep on repeating every 3 hourly. Now, initially by WHO, the 5 doses were the maximum doses which we can use. But now the upper limit of 5 doses has been removed. You have to decide on your clinical findings. So once you have given 5 doses and patient has not responded, so it is your discretion. You can give the additional doses or you can give the rest to the patient. Giving rest to the patient, it works beautifully. The success rate is very good. You give a rest for 24 to 48 hours, and then Again, you can repeat the regime, or patient usually they abort with the while on rest also. Now the FIGO has come up with a minimum rest of at least 12 hours, which also works the best. So this is about this, and minimum interval we have to remember between MIFI and meso has to be 24 hours. Now, if the patient doesn't respond, now before giving the rest, always reassess the patient. You have to reevaluate the patient again. Don't hesitate doing the ultrasound. It is so commonly available now. Rule out the rupture uterus, abdominal pregnancy also, although the percentage is very less common, but still rule it out. Rule out the wrong dates also. And if everything is fine, give her the rest for at least 24 hours and restart the regime, or the patient can abort also. But if you find the patient is unstable for any reason, then of course you have to resort to the surgical termination of pregnancy. Okay, over to you, Dr. Pratima, for next case.
Need to unmute me.
A low risk first trimester screening was reported in a prima gravida, and she was referred to us at 20 weeks in view of left-sided congenital diaphragmatic hernia. And yes, there was mediastinal shift, as you can see. The stomach was pushed down, and the stomach was down but very close to the bladder. So it was a stomach down diaphragmatic hernia. And the diaphragmatic continuity was made out on the right side, but not on the left. And of course, there was the SMA as well. We did a LHR ratio, and it was primarily bowel herniation, not the thing. As you can see, there's no stomach bowel there. So it was stomach down diaphragmatic hernia. So stomach down diaphragmatic hernia, Dr. Kuldeep, any other association? What else would you like to know in this? And what would you suggest to the patient? Dr. Kuldeep?
So, have I unmuted myself now?
Yes, yes. We can hear you now.
The moment we're looking at a diaphragmatic hernia, one will always have to look in for the status of the lung on the other side. Because if it's a left-sided hernia, I'd like to be looking at what the status is on the right side. I'm going to be looking at, because there could be in almost 50% of cases, association with 13, 18, or even 21, or Turner's as well. So those are the things. Then whether there is any left ventricular hyperplasia, I'd like to look in for that. Then is there any ventricular dysfunction? We would like to know that. But in terms of seeing the stomach, which is lower down, one will have to be very cautious as to, am I looking at something else going inside that or not? Whether is it the liver also herniating, or is it just that the stomach is there in the abdomen, but the bowel is herniating? To be honest, this is one of the rarest cases that I've seen with the stomach down and the bowel up.
Yeah. Yeah. We do get that. Okay, we've had a series of almost 5 to 6 cases, something like that. Dr. Anthony, on the operability of a left-sided stomach down diaphragmatic hernia or stomach up as well, what are the things that you're looking antenatally to prognosticate? We have already done the lung to head ratio. In this particular case, it was pretty low.
Yeah, so the LHR, of course, is one of them. But here again, like at this stage, very guarded counseling regarding the associated chromosomal and the cardiac. And I would tell them that if those are not there, and if it's a early pickup also is a bad sign for us, quite paradoxically. The late pickup diaphragms are what I would really give a much better prognosis to the family. Having said all of this, it is still one of the diseases that we are very hopeful about. So we are in a baby who has no other association, we are looking at a really good above 70% survival if you're looking at an isolated diaphragmatic hernia. And somehow over the years, at least in our literature, in the operated cases and their prognosis, the importance given to the stomach up and down has actually waned a bit from the time of when I used to read journals seriously during my PG days to now. And a lot of it now, in the good prognosis ones, we're doing it thoracoscopic. Just the day before yesterday, we've done a baby who was on day 1 thoracoscopic. So we're not even looking at what is happening below the diaphragm. If we're going up there, we're not looking at the orientation. We're just pushing things down and having an equally good outcome. So I think maybe a lot of focus has gone into this. What really affects, as Dr. Kuldeep said, is I think the other lung and the pulmonary hypertension and the cardiac. I think those are the killers.
Does it matter right-sided diaphragmatic hernia versus left-sided diaphragmatic hernia?
One, we see a lot more lefts than we see a lot more rights. And I think it's difficult to compare because a small right is usually missed, because the small right even postnatally is missed because the liver is occupied.
Some of them are reported as CPAMs, the congenital pulmonary.
Yeah. Then we get to work them up a few more months down the line, and then you pick it up. But I think numerically, most of us would deal with the left, and most lefts, if they've come through the pregnancy with no other associated anomaly, I would be very hopeful.
Yes. Well, I mean, hopefully we would have done, if they've decided to continue the pregnancy, more so to complete the genetic workup as well, because, I'm sure Dr. Chaitanya Datar would agree that, quite a few of them, I would say 20 to 30%, Dr. Chaitanya, would be associated with chromosomal genetics abnormalities, 1 in 5.
Yeah, so about 20 to 30% would be associated with chromosomal issues. So we would do a microarray. And obviously, in case this is considered for discontinuation, the test of choice would be an autopsy and DNA storage. By autopsy, we're getting about 15-20% more information than actually what we get on scans. So based on that, we could further work up the DNA. But obviously, we need a chromosomal evaluation and a single gene evaluation, because some syndromes like Fryns or Donnai-Barrow are associated with that. But there are a lot many single gene conditions which are now. There's one X-linked congenital diaphragmatic hernia which is also now defined. So we have to reach a conclusive diagnosis to be able to offer a proper counseling for the future pregnancies of the couple.
Yeah, and also just a word of caution with the stomach down diaphragmatic hernia and right-sided diaphragmatic hernia, maybe in these situations an MRI, additional MRI would help to kind of, yes, Dr. Kuldeep, would you agree with that?
Absolutely, ma'am.
Additional MRI would help to kind of solidify the diagnosis, because if they're going to decide that, do a termination or to do a continue the pregnancy with genetic testing, a second mode of imaging would be very helpful to kind of solidify the diagnosis. Although on ultrasound, we are reasonably
sure about
good at picking up that, but just because of for medical legal reasons as well, I would think. Okay.
Dr. Pratima, can I just say one word of disagreement on not disagreement, but a red flag. Because a lot of my diaphragms which are diagnosed antenatally then go ahead with the MRI. Sometimes the degree of confidence which the report says that this is eventration and this is not a diaphragmatic hernia. Sometimes it's very unsettling, because honestly, in some cases, a diaphragm with a diaphragmatic hernia with a sag is impossible to make out from an eventration. And the prognosis is very different for the two.
Exactly. I would be very cautious about reporting an event.
So what the red flag for me is the sheer confidence or the overconfidence with which reports are sometimes sent by the MRI reporting team. And that skews the counseling. It really skews the counseling.
In fact, you need to have really good people doing the MRI also. Fetal MRIs are very specialized subject. I always say this, that not every radiologist cannot report a fetal MRI. Fetal MRI has to be reported in the context of the gestational age, has to be reported in the context. So we need specialized fetal MRI reporting.
In the city of Bangalore, there are MRIs galore. So it's uncertified.
Everywhere. So you have to be very picky and choosy where you send them for the MRIs. And
Dr. Pratima, Dr. Pratima, can I just add one thing? When we're looking at the stomach in the abdomen, and one will have to really have the index of suspicion, why are we thinking of a diaphragmatic hernia? So in terms of when the heart is getting pushed to one side, one will have to be very careful of seeing the diaphragm, the continuity of the diaphragm. So that will always have to be there, so that we do not make a mistake of whether it's a right-sided one or is it just the bowel and the stomach is not going up, because that's what's normally expected, that the stomach is going to be in the retrocardiac area.
Yes. Yeah. In fact, the closeness of the stomach to the bladder, which doesn't happen normally.
Yeah.
And that is a good clue to say this is a stomach down diaphragmatic hernia. So, of course, they opted for termination, and this was termination at around 20 weeks, 21, 22 weeks. So, Dr. Richa, you have your inputs on this one, please.
Yeah.
Ma'am, can I take a moment to just introduce Dr. Nikhil, sir? Dr. Nikhil Datar, sir, has joined us. He's a consultant gynecologist and medical director at Cloud9 Group of Hospital in Yashoda Hospital, Mumbai, and he's visiting professor at Maharashtra National Law University. Welcome, sir. Welcome to the webinar.
Yes.
Yes,
Okay,
ma'am.
so now this patient again, she is for MTP and she is at the private hospital now. Now, this particular private hospital was approved for doing MTP till 20 weeks before. This is about the before amendments now. Now, can this particular patient undergo MTP in this hospital now at 21 weeks? Yes or no? And second question is, how can a health facility get approved for MTP? I have already pointed out government hospitals don't have to take any kind of approval. They are already approved. Private health facilities have to take the approval from the government. District level committee has to approve them. So what is the procedure like? What about the inspection, suspension, cancellation of the license? Anybody can answer.
Richa, when it came to the 20 weeks and 24 weeks amendment, it lot actually was deferred in the various actually the centers according to the whim of the appropriate authority. In Maharashtra, the Secretary of the Health actually gave the orders that you'll have to just ask actually that particular center and to give one copy of that particular certificate and a letter, request letter saying that now please make change of 24 weeks on the certificate. That it was because that center was already approved for the 20 weeks. Only this amendment has happened to 24 weeks now. But that is not the case in every district. Many of the district I know that they ask for the again all documents which were required and the also the affidavits which are required. So it differs from district to district, but then the state secretary need to intervene accordingly and they need to do the needful for that particular case. And about the inspection, suspension, cancellation, again for the inspection the district team comes. Previously I remember that the when before decentralization it was a big deal to get the MTP center recognized, but when it got decentralized, comparatively getting registration is easy. Suppose they don't report and suppose on inspection the record is not kept confidential, then definitely the appropriate authority thinks of suspension or cancelling that particular MTP center.
Okay, so I have only Dr. Milind is there. Anybody can also contribute. As sir has said that private hospitals, it depends from state to state whether they have to reapply for the registration or the same registration will hold good. What is the opinion of other panelists? You must also be doing MTPs in your center because it is such a small procedure, I believe. So what is your say on this? Dr. Seetha, you must also be doing.
There is a question. There's a question in the from the audience, Dr.
Yeah, we will take up the questions afterwards. Dr. Seetha, yes.
Yeah. So, so what were you asking? Sorry, specifically, I was just...
This is a first question only. Like this particular hospital where this patient is there, and that hospital is a private hospital which was approved for MTP till 20 weeks before amendment. So now can this patient can undergo MTP in this particular hospital, or she has to be shifted to other hospital?
No, I think it needs to, they need to have a fresh approval for 24 weeks as well, because by the amendment we can't really continue with that. So according to my knowledge, they need to be shifted to a place where the new amendment is in place for it to rule out any.
After the amendment, now the MTP Act amendment, they have clearly mentioned that the centers which were approved till 20 weeks, it means they are approved for 24 weeks. This is the second clause. So they don't have to apply for re-registration. They just have to update their form B. And regarding how to get the approval, this is for the private hospital. So you have to decide whether you want a category A approval, that is MTP till 12 weeks, or category B approval, that is MTP till 24 weeks. After 24 weeks, approval to the private hospital or health facility is not given, but it again depend upon the government. If they select particular hospitals or the medical college after 24 weeks, that can also be taken. But as of now, the registry approval is given to private hospitals only till 24 weeks. So you have to have the infrastructure in place before you apply for the approval. So if you want the approval till 12 weeks, you should have this 5 infrastructure things. That is, you should have a labor table, resuscitation equipment, sterilization equipment, emergency drugs, and transportation. Now the detailed list is already there in the website. You all can check about the drugs and the equipments. So this is the basic infrastructure for 12 weeks. And for 24 weeks approval, in addition to this 5 things, you should also have the OT table for doing the surgeries, and also the facility of the anesthesia, and emergency drug should also be there. So this is a basic infrastructure which you should have. And for getting the approval, you have to apply in this form. This is called as Form A. Now, owner of the hospital has to sign here with the place and the date. Now, after that, now that there are the checklist along with the Form A, you also have to submit the address proof of the particular hospital or the health facility. I'm repeating, I'm talking about the private setup, or the rent agreement if it is a rented one. Then the qualification of all the technical manpower, doctor, then their registration, nurses also, OT technician also, and your nursing home registration paper also has to be there. Agreement of biomedical waste management also you have to put a copy, and agreement with the state pollution control committee. Now all this thing is there online, and you can have you can apply for the agreement online also, so that it is very easy. And if you're having the lab in your place, you have to also disclose the name and the name of the lab and whoever is taking care of that lab. And also you have to have the agreement between the owner and the doctor who is appointed for MTP. So these are the basic 8 documents which you have to submit. Apart from this, again, the local authority, it depends. They can ask for other extra paper for the approval. Now, how the approval thing is sought is again a Form A you have to fill, and in your area you have to submit to the CMO or the district health officer. And within 1 or 2 months, they are supposed to come for the inspection. And suppose if they come and they find any kind of deficiency in your place, they give the time to rectify your deficiencies, and again you apply for it. And once the CMO or the district health officer, they are satisfied with your center, then they will recommend to the district level committee, and then district level committee approves your place and give the approval in this form. This is called Form B. Now here form, it will be clearly written that your hospital is approved to do the MTP till 12 weeks or 24 weeks, and then seal of government will be there. Now, why I am telling that you have to get your Form B updated. Again, the people who have got the approval till 20 weeks before amendment means you are approved doing MTP till 24 weeks. You don't have to apply for re-registration. Get your this Form B updated, because you have to display this form in the place wherever you are doing the MTP services, and your patient should not get confused. So this is about the how to take the registration. Now, once the approval is given, approval is permanent, renewal is not at all required. And inspection also, frequency is not at all fixed. They can come on their own. Usually the CMOs, they come for the inspection. If they hear that the MTPs are not done properly or not under safe and hygienic condition, then they come for the inspection. And suppose if they find the fault in anything, then they can recommend for cancellation or suspension of the license for MTP. So you have to keep up the standards for MTP norms. Dr. Nikhil, would you like to add anything? Or else we'll go to the next case quickly. Okay, over to you, Dr. Pratima.
Thank you. So we move on with our next case. Again, for prima gravida, first trimester screening was, with the monochorionic twin, at 12 weeks. And there was a discordancy in the nuchal translucency, 1.3 and 2.2. Of course, there was a discordancy in CRL, NT, and abdominal circumference. And she was advised the double marker. And interestingly, we noted a very low beta HCG. You don't know what's the significance at this point of time. So what I would like to say, so that obviously the patient goes back to the obstetrician. So that's why I put Dr. Milind Shah ahead of Dr. Seetha Pal, who's contributing to the fetal medicine part of it. So Dr. Milind, this is the report that you have got. and there is a discordant CRL, but the risk reduction is good. So what would your, what would your counseling be for her?
Yeah, actually, I was speaking on telephone, but let me see the report quickly. Yeah, discordancy 17% and NT 40% and XC 50% is biochemistry. Yeah, okay. Seetha, can you take this? I was just on the phone and actually I'm unable to see the entire things on my screen.
Sure, sir, no problem. So
yeah,
I
please.
think the MCDA twins, we know that they are they do have increased chances of, because of the vascular anastomosis and fluid imbalance. Per se, when we talk about singletons or DCDA twins, because the genetic material is different, increased NT, the first thing you will think of is aneuploidy risk. But in MCDA, it is different because of the vascular anastomosis and the fluid imbalance that they might have. This NT discordance might not actually be telling you the risk of aneuploidy, but telling you that there could be other problems related to the vascular anastomosis. So I think
now you're going to bring her back for...
Yeah, so she is now around 13, how much she is? 13 weeks.
13 weeks, yeah.
Yeah. So I think I'll call her back in about 2 weeks' time, and see how things are going. Because,
so, by default,
typically by default should become.
Irrespective of
and then we are looking at predicting the TT because of the discordant CRL as well, selective FGR or TTTS.
You'll just be more cautious in this particular case, but that 16-week rule remains, I guess.
Yeah, definitely.
So all
and then also
back at 16 weeks for enhanced surveillance, irrespective of discordancy. It just happened by chance. There was some discordancy in 3 markers in this particular case. So, well, she came back for an early anomaly scan, and this was the findings where there was a discrepancy in weights. So there was a selective fetal growth restriction, type 1, because the umbilical artery Doppler was normal. And the amniotic fluid, of course, of the smaller baby was on the lower limit of normal. So would we still carry on with conservative management here?
Yeah, as of now, we can still carry on because it's type 1. But telling her what could the possibilities be. And
so 1 week or 2 weeks now for the surveillance follow-up.
The umbilical Dopplers were normal, you said, yeah?
Yeah. Type 1.
Yeah, type 1. I would still call her back at around 2 weeks only. Or 1 week rather, actually.
1 week. I mean, the moment you have actually diagnosed a problem.
With the FGR, definitely 1 week, yes.
So then it becomes weekly. There is nothing at all if it's completely, you're not given a diagnosis yet. So the moment you mention the word TTTS or SFGR, and this is primarily because the interventions are much better if you intervene at the right time.
Early, yeah.
Early enough, right? So coming back at 18 weeks, we noticed that there was a discordant anomaly also. Was heavy vertebra in one and the lumbar scoliosis in the twin one, which was the relatively smaller one. Weight discordancy had gone up to 25%. So again, that was the visuals there. And I think now is the time that we have to consider, do we need to consider?
We need to at least offer and speak to them about it, yeah.
Yeah, there's a discordant anomaly, but hemivertebra with mild scoliosis.
Not too much, yeah.
Not too much, right? So we do have the option of continuing as well, but as some parents want very specifically to kind of consider intervention. Do we have Dr. Malhotra here yet or not yet?
He's in the OT. Somebody's written, yeah.
So, all right. So, okay, so we discuss all the options, and this particular couple opted to undergo selective reduction because also the weight discordancy had, increased significantly by the time we reached 21 weeks. They said we are worsening of the selective FGR, and we have moved from type 1 SFGR to type 2 SFGR.
Type 2 now.
And then although the anomaly were not so significant, hemivertebra and a small VSD, but there were concerns about other conditions as well. So they opted to undergo interstitial laser. Follow-up of this baby was good, and the baby had, had a preterm delivery, but a good weight of that, right? Now, in this particular case, what I would like you to contribute, Dr. Richa, selective termination in multiple pregnancy. Is there a rule?
Yes,
is there an MTP Act for that at all?
Yes, exactly.
Constantly asked question.
The moment I saw that case, I was like, okay, good, now we will cover that. So, okay, so my screen is visible, right?
Because I presume we are not terminating this pregnancy.
Okay,
right?
so now you have done the fetal reduction for this particular one fetus.
First question is it allowed?
Yeah. So, okay, so that is fine. Now, I just want to ask any of the panelists, now, will this selective fetal reduction falls under the purview of MTP Act or not? Whether you have to fill the forms, MTP forms, what are the mandatory MTP forms, and what are the other such cases which may or may not fall under the purview of MTP Act? Anybody can answer. Dr. Indranil and Dr. Nikhil Datar, sir, you are also there. You can answer. I can't see anybody here. Am I audible? Am I audible? Yes.
Yeah, Nikhil, is you audible?
Dr. Nikhil, you're there. Yes.
So the current MTP Act, the way the MTP has been defined in Section 2, is any medical or surgical procedure to terminate the pregnancy. What is the meaning of word pregnancy? Pregnancy is the state of the mother to have fetus in her womb. And what is termination of pregnancy? You are removing that state of the mother from being pregnant. That is why if you are doing a selective fetal reduction in a multifetal pregnancy, since you are not disturbing the state of the mother from being pregnant, the current MTP Act, okay, unfortunately, okay, allows you to not fill up the forms and still go ahead and do selective fetal reduction. My understanding is that this is actually not the correct definition, because if we are going to define termination of pregnancy is basically any procedure which snatches away her status of being pregnant without giving any importance to the intention for which it is being done, then technically miscarriage, missed miscarriage, ectopic pregnancy, or even a post-dated pregnancy, okay, will also come into the purview of MTP Act. So, in my opinion, the terminology or the definition of the MTP Act needs to be completely changed. It should be on the basis or the focus of the intention for which this whole termination is being done. And if what I am saying is right and if it is accepted by the court, then after that MTP Act, after the word MTP definition will get changed. After that, you will have to fill up.
Yes. So very rightly said.
Can I ask you, Dr. Nikhil,
So,
why are you saying unfortunately? Because fetal reduction improved outcomes significantly
yes, exactly. So, Dr. Nikhil, in my simple language, if I say,
one second. The reason why I'm saying unfortunately is we are not saying that don't do fetal reduction and improve the outcomes. We are saying that if you don't want people to start filling up MTP forms when you are delivering a post-dated pregnancy by doing a C-section, then you will have to bring a definition which says that when you are abolishing the life of the fetus or you are doing any procedure, okay, whereby you are removing or reducing the chance of a survival of that particular fetus, that should be called as MTP. And this is what is the definition of abortion across the world. So if you look at fetal reductions happening in United Kingdom, they do fill the same forms under Abortion Act. Why? Because for them, the definition of abortion is very clear, and it is used. It is Abortion Act of United Kingdom. It is not this whole MTP is a Indian carved kind of a terminology. It does not exist anywhere in the world. In the world, it is called an Abortion Act.
I would think that would actually set a very difficult or dangerous precedence, because many times when we are doing the fetal reduction, particularly in scenarios in monochorionics and things like that, we really don't have that much time not to fill forms. Filling the forms is easy, but to wait for the approval,
No, but who is asking for approvals?
No, but why do you fill the, I mean, we fill the forms as in the
approval is for the place, Dr. Pratima.
Approval is not required, no?
Who is
Approval
asking
is
for
already for the
approvals?
place. Okay, I will just cut short. We are running short of time. Dr. Nikhil has rightly answered this. I think everybody's query is solved. See, MTP means that we are terminating a normally localized pregnancy. And here the selective reduction means we are giving the chance for the next baby to grow. So reduction does not come within the purview of the MTP Act. Similarly, other abortions like missed abortion, ectopic pregnancy, incomplete abortion, all these things also doesn't come. Cervical pregnancy.
Currently they will, if you are saying that you are terminating the status of the mother from being pregnant, in the very narrow understanding of this definition, an ectopic pregnancy will also amount to be medical termination of pregnancy. A missed miscarriage will also unfortunately become MTP. And if I am
Induction of labor also.
Yes.
induction of labor will also amount to be MTP.
Yeah.
So it's a very
now,
sorry state of affairs that we are still continuing to not object to this definition when significant proportion of gynecologists are doing all these procedures, and it is the greatest stupidity on the earth that if at all if we are asked to fill up a form for induction of labor saying that it is medical termination of pregnancy, I don't think anything can be more stupid than that. But if you really look at the definition, this is what it means. And
okay,
to
so for MTP,
nobody will object.
Yes. So coming to the documents for doing MTP. So these are the 4 documents you have to know very clearly that we have to fill this, whether you are using the medical method of abortion or surgical methods. In first trimester, second trimester, or any period of gestation, you have to fill these mandatory 4 forms. This format also has been given by the ministry. So consent form you have to fill if you are doing the MTP. The consent of a woman who is more than 18 years, she can give the consent for MTP. And husband consent, relative consent, by law, it is not at all required. Now, if the patient is a minor, less than 18 years, or if she's or mentally unsound, then the guardian will have to give the consent. So this is the consent form. Format of this you can have in the local language also. Now, for doing the MTP till 20 weeks, this is the form 1 which you have to fill. One RMP details has to go. He has to sign here. And these are the 5 indications which are listed here in case you forget it. Now, Form E, this is a new form which has been introduced after the amendment for doing MTP between 20 to 24 weeks. Now, here the details of 2 RMPs has to go. And now 7 categories of the women are already listed here. You have to choose whichever is most appropriate. Signature of 2 RMPs has to be put here. So this is the Form E. Now, this is the Form 2. All the hospitals who are doing the MTP, you have to fill this form and you have to send to the district authorities first week of every month. Now, the past 1 month of MTPs, what you have done at different period of gestation, like 9 weeks, 12 weeks, and after that, religion of the woman, total number of the women in different religion, you have to write. What contraception, total number you have to write. Reason also for termination, depending upon your center, whether it is approved till 12 weeks, 24 weeks, or if it is beyond 24 weeks. Now here the family planning head has to sign and head of the department has to sign here. You can submit this online also depending upon the policy of your local state. So this is about Form 2. This is an updated form. There is a slight change in this form compared to the previous form. So I request everybody to take the updated forms and use these documents. Now, this is the Form 3, very important. Now, this is actually a register. You have to start your register from January of every year. You have to write the serial number, and then there are the 16 columns which you have to fill. Now, the date of admission, name of the patient, her details, age, religion, address, then gestational age, then indication you have to fill, date when you are terminating, and the date of discharge. Now, there are before the amendment, there were only 14 columns. Now, after the amendment, 2 more columns have been added. That is method of MTP, what method you are using, that is 15th, and contraception also, what the patient has opted. So there are the 16 columns which are fixed, and you have to make your register this way. All the MTP forms, they are very confidential, medico-legally very important. You have to keep under custody properly and preserve all these documents for at least 5 years. Now, Dr. Pratima, we go to you for the next case.
So probably we will not have that much time. So if we can.
7:30. Okay, we can take a 1 or 2 case.
Yeah. Okay. So anyway, coming back. So for the records, for fetal reduction, you do not need it's not MTP. I mean, it's allowed for the right reasons. So this is a 22-year-old married to a first cousin and was referred to us for the first time due to short, long bones. And of course, as you can see, all the long bones were much well below the 5th centile. And the femur foot ratio also was very low. The thorax was narrow, bell-shaped thorax. These were the visuals. You can see there's quite a significant discrepancy between the abdominal circumference and the thoracic circumference. The kidneys looked enlarged, and there was this kind of contraction discrepancy between the thorax and the abdomen. So there was a bell-shaped thorax also. So, and in addition, there was significant polyhydramnios. So we gave them the possible diagnosis of, prognosis is obviously guard at 30 weeks for this significant polyhydramnios, lethal skeletal dysplasia. So how would you counsel this patient, Dr. Seetha?
Yeah, so this is it's always difficult with skeletal dysplasias because they present late, and and the main important thing to diagnose is whether it's a lethal or non-lethal. And as you can see, there's associated polyhydramnios. You see, look at the shape of the thorax, and if there is a significant thoracic, this compromise, yeah. So obviously that is going to affect the baby in terms of pulmonary hyperplasia, and it just looks more like a skeletal dysplasia. But in skeletal dysplasia, it's very difficult to give an accurate diagnosis at this stage. But looking at the entire picture, the prognosis doesn't look very good. So we might have to tell them and then give an informed. Also, yeah. And then look at the foot femur ratio.
It's very low.
Sorry. Yeah. Okay. So everything is pointing out to a lethal skeletal dysplasia only.
So now the patient comes to you, Dr. Milind, to say that they have given me really bad prognosis. So what next? 30 weeks. The mother is not very tall. The mother is about 4'9". Dr. Milind, are you there? Okay, we have another obstetrician, Dr. Indranil. Can you take up this case, please? If they come to you as a gynecologist, what would you? No. Okay. So, yeah, are you there, Dr. Indranil or Dr. Milind? No. Okay. So, Dr. Richa, what would you tell this woman? I mean, as my co-moderator, I'll have to ask you an obstetrician to contribute to this.
No, so yeah.
Yes, no point. Yeah, I will go for termination only. Dr. Indranil, yes.
Hello.
Yeah, we can hear you, Indranil.
Oh, now he's muted himself. Yeah. Dr. Indranil, please unmute yourself and speak up.
Yes, you are audible.
Is there some problem with this audio? Dr. Richa, kindly go ahead with this.
Yeah, yes, I will terminate the pregnancy. Can you stop your screen share, or if you want to investigate the baby further?
Yeah. So basically, it was quite a significant one. And what about doing amnio drainage prior to considering termination? Because you're going to have a baby which is going to be moving around all over.
Yes. So I will. Are you covering? Can you stop your screen share, Dr. Pratima?
Yeah, I'm asking
this baby is decided for termination. Okay. So, okay, I'll share the screen. Yeah. So quickly, I'm going now. Okay. So this particular patient, she is at 30 weeks. 1 second. Okay. So she is at 30 weeks. And now she is for termination. There's no doubt about it. Now medical board will have to take the decision because she is after 24 weeks. Now, can anybody quickly tell what is the composition of the medical board? Who are the members? And medical board, how quick are they in their decision? Anybody can? Anyone?
I think
so basically,
I think it is a weekend. It is a weekend, and
no. So the medical board is usually not the medical colleges. They have it, and they have a gynecologist. They have a.
So it is between Dr. Pratima and Dr. Richa. I think the conversation.
Can you hear me? Can you hear me?
Can you hear me?
Seetha, yes. Yeah.
Yes,
Yeah.
Seetha, we can hear you.
Yeah, so the medical board is usually one of the medical colleges that has been constituted to give approval for these cases beyond 24 weeks. It consists of an obstetrician and gynecologist, usually the head of the department there, and then you have a pediatrician and the one of the management people, and sometimes they have a geneticist as well. Now, usually they take the decision. In some colleges they tend to admit the patients because it is difficult to get all of them on board, but some of them give it on an OPD basis as well. And then the decision has to come within 24 to 48 hours max. So that is very quick regarding that. And the third question is, can this medical board take decision with normal fetus? So that is what they need to discuss with seeing the reports and the genetic other reports as well, if they want to take on board any other genetic counseling or geneticist. With that decision in mind, normal fetus, I don't know what you exactly mean with normal fetus. I mean, it is because it is abnormal, we are going in for termination, isn't it? So, what do you intend to say by
Normal,
that?
I mean, if it is suppose a sexual assault
Can I add to
which
Seetha
has
madam?
come, that
Yeah,
question
sure.
I had put for Dr. Nikhil. I'll be going to Dr. Nikhil later.
Hello.
Okay,
Dr.
fine.
Indranil, first and second question. Do you want to
Yeah,
continue?
no, actually, what madam told, Seetha madam, is correct, but I think the radiologist will also be in the team of medical
Yes,
board.
yes. Yeah. Yes.
This is also there, yes. Yeah.
Radiologist also has to be there. I think officially has to be there.
Yes,
And
yes.
preferably the
So,
medical super of the superintendent. If it's government, it will be the superintendent, and in the medical college, it will be the
yes. So as per the amendment, see, 4 people have to be there: gynecologist, pediatrician, radiologist, and any number of members notified by state government. Now, different state, they have different policy. From Delhi, I'm telling you, gynecologist, we take head of the department or any senior obstetrician. Then pediatrician, neonatologist also you can take depending upon the case, and radiologist, and even the fetal medicine specialist or geneticist also we should take if we have a case which is a tricky one. And then medical superintendent, as you said, also will be the member. And for private hospital, the medical board member will be from the government of hospital, which is nominated. But one thing we have to remember, at least one person has to be a woman out of 6. One has to be the woman.
Yeah.
Now, medical board, how quick they are now, it is their duty to give the decision within 3 days from the day they have got the application. So they have to say yes or no for the particular case regarding MTP. And suppose the medical board say yes for the MTP, then also it becomes their duty to see that MTP is done within 5 days of receiving the request for MTP. And they have to give their approval or denial in the particular format in Form D. Now, this is the format of the Form D, where you can see the patient details are written here, and then the investigations and reports, and all the board members' name and signature also will be there. So this is a format on which they say yes or no regarding particular MTP. Now, regarding as far as the GCA goes, now congenital anomalies means which are incompatible, and also if there is a risk, it is not that it has to be confirmed that there is a structural anomalies or any confirmed. Even if there is a risk that the baby can be born with a handicap, physical or a mental, so those are also included in this thing. Now, going back to the third case, Dr. Nikhil, I would like to have your opinion. Now, suppose this is out of box, but very important. Sexual assault victim comes adult, and medical board has given the medical board. Now, can this particular medical board take the decision for doing the MTP for this patient after 4 weeks?
I need to draw your attention primarily to the indications for doing termination beyond 24 weeks or termination up to 24 weeks. When we have Form D, which categorically says that if there is a normal fetus, then termination at best can be done up to 24 weeks. If that is the law of the land and rules and regulations under the law, how do you think that a medical board, which is merely of the doctors, can supersede the regulation or the rule which is passed by the parliament? Hence, it is an impossibility that the medical board will, because if medical board says, oh, she's a rape survivor and that's why let us allow termination at 26 weeks, then it means that they are superseding the mandate that is given by the rules under the MTP Act, which is passed by Parliament. So they obviously cannot have any kind of an opinion-making strategy going beyond 24 weeks when it's a normal fetus.
Yes.
But courts are open. Courts can still continue to entertain. And courts have the power to supersede the rules under the MTP Act. So the courts will have to be approached. The courts may direct. Now you have to understand the difference. Legally, the difference is today the same committee when it sits under the MTP Act vis-a-vis a committee when it sits under the directions of the High Court, their powers become different. Their powers become different.
Yeah.
So under the directions of the court, if the court has asked them the question, such as A, can termination be done? The board can say yes. They will ask, will it be more risky to the woman's life? They will say no, it will not be more risky to the woman's life. Then this opinion can be understood by the judges, and judges can have the power to supersede the rules and say, okay, if that is the case, I am allowing termination of pregnancy to this girl. So
Yes.
the correct medical legal stance will be, if somebody is approaching them under the existing framework of MTP Act, then the medical board shall not entertain any such kind of a case unless or until it is laced with a fetal abnormality.
Yes. So this is
So,
very clear to the audience. So suppose if you get a case like what we are discussing, fetal congenital anomalies after 24 weeks, then now the medical board will take the decision regarding the termination. But suppose you get any patient who has a normal fetus, for example, sexual assault victim approaching to you wanting MTP after 24 weeks and a normal fetus. So in that case, you have to direct the patient. She has to file a writ petition, go to the court will ask the board, and then the decision for termination will be taken. So this particular medical board which has been formulated under the purview of MTP Act will take the decision for the anomalous baby only after 24 weeks. Dr. Seetha, yes.
Yeah, I just wanted to ask, because I recently had a case last week. Is it mandatory for the medical college to say that the termination should be done in the medical college, or they are allowed to go and get it done in a private medical college?
Yes,
this
it
is
not, yeah. So see, private medical college has to be approved. Okay. If
No,
that
it's
case
approved. Like, I will tell you, I had a case. They went to a medical college, and she was almost 26 weeks for a rare genetic anomaly, which is different. I won't discuss that. But they said it was mandatory for you to get the termination done here. And the patients obviously didn't want that because it was, college, medical college sort of ambience was not good. They said they wanted to come to a private, but they wouldn't allow. So they said you either go to a different medical college, and who will give you permission. So I got totally
Dr.
confused, and
Seetha,
the patient lost 2 weeks.
Yeah, so I just want to clarify again because I've already highlighted this point earlier. See, private medical college or a private hospitals, they will get approval only till 24 weeks MTP. Beyond 24 weeks, the approval is not
The
given to them.
medical board will say that they will give you the approval that the pregnancy can be terminated. But where the pregnancy can be terminated, what I'm trying to ask.
I will come to that.
Actually,
Because I have dealt with this particular case.
See, I will just clarify once, Dr. Seetha. After 24 weeks, private hospitals or medical college, they are not supposed to do the MTP because they will not be getting approval. But if they are notified by the government, because in Delhi also certain private medical colleges and hospitals, they are notified and they have the board there for doing the MTP, then you can go ahead. Okay. So am I
what exactly
in Bengal,
particular case? No, I get your point, Seetha. I get your point. Yeah, In this particular case, for example, it was a private setup, and I privately approached the medical board, sent it to the medical board. They repeated the scan and the counseling. That was fine. And this happened within 2 days. And then they approved the termination of pregnancy, referring them back to the obstetrician. Yeah, Finally did the termination because the patient wanted the termination to be done with her obstetrician. So they did not change the place. Now, in a similar case,
a few years ago, before the advent of medical board review, we had a late diagnosis of a severe cardiac anomaly with a genetic abnormality. We had approached the court to that, and that they specifically the couple requested the termination to be done in a private hospital, and the court approved it, right? So in all cases that we have dealt with, all our medical board has approved the termination to be done
at the choice of the patient.
Referral, from where.
But you can always change the choice also, Dr.
No,
Seetha.
but Seetha,
Suppose for a
in
particular
Bengal,
patient, yeah,
So
Dr.
we
Indranil,
can
one minute. Suppose a board has directed a particular patient to a district hospital, MTP, or any one center, so she can always ask that center to refer her to the hospital, whichever is near to the hospital of her choice. You can always change. You don't have to go to the board again and again. The referee.
No, that is what I'm asking, whether I know she asked and she was denied, and that is why I'm asking whether it is mandatory for for the patient to do that, because she was not comfortable. She didn't want to get it done there. So
Seetha, I will ask you a question.
Sure.
The reason why I'm saying this is because other people have done whatever they have done. I have in fact recently filed a writ petition for one of my patients and got an approval to terminate the pregnancy in my own private center. Okay, when she wanted. So it's a similar kind of a situation, 25, 26 weeks, substantial cardiac abnormality, did not want to go to JJ hospital for terminating the pregnancy. JJ board approved termination of pregnancy. Question was where it should be done. Patient wanted me to do it in my private setup. Okay, now the question in front of me was, am I allowed to terminate the pregnancy? Answer is, as a doctor, I am allowed to terminate the pregnancy. The question is whether the center where I want to terminate the pregnancy, whether the center has an approval to terminate the pregnancy. Now read Section 4 of MTP Act. Section 4 of MTP Act says that there are two types of places where termination can be done. One type of place is government hospitals where no approval is required. Nobody applies for approval, nobody gives approval.
It's automatic approval.
Second type of centers are supposed to be non-governmental hospitals where you have to apply for termination of pregnancy under Form A, and the district committee is supposed to give you the approval for allowing.
I understand that. So in our case, the Apollo hospital where I'm working.
Listen to me. Now see Form A. Form A is a part of rules under MTP Act. I think somebody, Dr. Richa or somebody had shown that Form A, if I remember.
Yes, we have covered that.
Form A has only two categories, up to 12 weeks and up to 24 weeks. Which means your Apollo hospital, our Bridge Candy hospital, Jaslok hospital, whichever hospital, or for that matter, even Wadia hospital in Mumbai, which is a non-governmental hospital, the form that they will fill up, since there is no place only for you to ask for permission beyond 24 weeks, there is no question of giving permission beyond 24 weeks. So it technically means that no non-governmental hospital can perform termination of pregnancy beyond 24 weeks. Now, most of the people here and otherwise outside, oh, but the board said you can terminate. But the board doesn't have authority. Board has authority only to decide whether the given case requires termination of pregnancy or no. It does not have an authority of deciding the place of termination. The board does not have it. That authority is vested with the district committee. It is not vested with anybody else. And district committee can only approve applications which come to them. Now, if you are applying in application form only, if beyond 24 weeks wala category is not there, then how can you apply in the first place? Now, if you cannot apply, how can it be approved? And that is why I have highlighted this particular thing in the High Court. The addition of the Advocate General of Maharashtra State accepted that probably there is an anomaly in the form itself. So this is an unintended or unintentional lapse on the side of the government, where they ought to have added one more category, which probably they have forgotten to add, because government has no intention of restricting MTPs beyond 24 weeks or something like that. Okay, Baba, we don't want to have private sector coming in. Probably not like that, but unintentionally, probably there has been a lapse. And because of that lapse, currently there is no category of the sort where you are a non-governmental hospital and wanting to do termination beyond 24 weeks. So I have highlighted this, and in this particular matter, the court went beyond, and court allowed me to terminate the pregnancy in my own, that is Cloud9 hospital, okay, where I undertook the termination of pregnancy after fetal reduction. I have terminated that pregnancy beyond 24 weeks. The matter is still open. It is me and my patient versus State of Maharashtra and Union of India. The matter is supposed to come up again for hearing on 30th of June, and we are expecting Union to file their reply. And probably once that is done, these things might change. So they may have to change that Form A. They may have to add that category. After that category is added, then this problem is going to get solved. Till that time, technically speaking, you cannot terminate a pregnancy beyond 24 weeks any non-governmental hospital till that point of time, unless and until they approach the court, take my judgment, show them this particular order, then it is easy for you to get an approval. Otherwise, it is technically speaking not correct. And once again, reiterating that today most of the government hospital where these permanent medical boards are set up, they are extremely disturbed because of an abnormal amount of load of patients that they have to handle for doing these MTPs. They pretty much want that this load is shared by the private sector.
True.
So they are more than happy to shun the patients to private sector, telling them, yeah, you can do. But ask them this question, look at the law of the land. Do the permanent medical boards have the capacity to authorize a center for doing termination of pregnancy? That authority is not there with them. So if that authority is not there with them, how can they say and how can you listen to them?
Okay.
So the point here is the two
I
medical
have a point,
colleges.
Dr. Datar. See, when you're saying that post the reduction, it is an IUD, right? So somebody has to induce.
I don't know that, because I don't understand the definition of termination of pregnancy in itself. If you are saying that termination of pregnancy means you are removing the status of the woman to be away from being pregnant, then whether it is IUD or otherwise, it just simply does not matter. So what we are doing, Madam Pratima, is that we know what is the problem, but we want to take at different points of time different meanings which suits us, and we try to apply with in fragments. But if we look at it collectively, the whole thing boils down to only one question, that what do you really mean by termination of pregnancy? If you are saying that IUD doesn't become termination of pregnancy, but the MTP Act, the way it has defined MTP is what? It is saying that you have to, any medical or surgical procedure to terminate pregnancy. Now, terminate pregnancy means pregnancy, whether it is miscarriage, IUD, whatever it is still pregnancy, and you are terminating that pregnancy. So I don't understand this particular definition. It needs to be changed. That is what is my understanding. Now, once it will get changed to what you are saying, then IUD will be out of termination of pregnancy, but fetal reduction will be in the termination of pregnancy.
Okay, so now we are running short of time. So quickly, one last aspect of this. I think Dr. Seetha, your question is answered.
Yeah, a bit, because what I'm upset about is the two medical colleges have given two different sort of, one medical college says you can terminate in the choice of the patient, the other one says no. So patients are thoroughly confused, and I'm anyway, let's not dwell on this.
I think, Seetha, you are, sorry to say, but frankly, and you are my friend, so I can say it. I'm sure you will not take it other way, because being a friend and my classmate actually. But the truth of the fact is, there can be n number of people who can confuse you. But why are you getting confused? You need to understand.
No, I'm not getting confused. The patient gets harassed. The patient gets harassed.
Patients are getting confused. People are getting. Why are you getting confused?
Can we move on to the other topic, Dr. Nikhil?
Yeah. One more question. I also heard something about how do you decide whether this is an abnormality which is worth terminating or no. and there was some kind of a discussion that happened, and I am going to solve this. It's very simple. We don't have to put our head into it. If you look at the GR which was passed by the Ministry of Family Welfare, none other but Ministry of Family Welfare, Government of India, which forms a part of my petition.
Yes, I have shared.
They
I have
have
shown
given,
in my
they
presentation.
have given 72 abnormalities as substantial and serious abnormalities, and I think you will very rarely find any abnormality which is out of this particular list of 72. So practically that problem is already solved. That problem is already means now there is no qualitativeness into it. It's a quantitativeness into it, because you have to just simply look at it. Yes, 72 में है क्या है, so it is substantial. Chapter over.
Yes, that
Thank you for that.
document I have shared, Dr. Nikhil, in the beginning, which is a part of our GCPR also, that I've already shared.
Yes.
Now, this is a last point of discussion we are going to do. See, now gestational upper limit, it is increased. Now we know that baby may be born live. So the question of doing the pre-MTP feticide or cardioplegia has to be considered in the anomalous fetus only, not in the otherwise healthy baby. So now our pre-MTP cardioplegia or feticide is in the recommendations now. And if the patient doesn't opt for it, because this counseling has to be done before you are taking up the patient for MTP, you have to counsel the patient regarding feticide part also or other options also. So I
You
will
asking
ask
this
you,
question
Dr.
to me?
Nikhil, only. Yes, I will ask you only.
So I will make it very straightforward and simple. When you are terminating a pregnancy beyond 20 weeks and now 24 weeks, we are supposed to follow that GR, okay, which was passed by the Ministry of Family Welfare, Government of India. In that GR, there is column number 5, subclause C, which says that if you are terminating a pregnancy beyond 24 weeks, then you are supposed to do feticide, and you have to ensure that a dead fetus is born as a dead neonate or dead child on this particular earth. Now, unfortunately, the problem is that most of the committees are not aware of this GR. Number one, the GR was passed earlier on and then came the amendments. So whether the GR continues to be applicable or no, that we do not know. The amended MTP Act and rules thereunder do not have any sort of a mention of this particular GR. So that's why its applicability becomes questionable. This is where the problem is, and that's why, and lastly and most importantly, the biggest trouble that we have is all these permanent medical boards. And somebody spoke about the constitution of permanent medical board. According to me, permanent medical board constitutes of only one RMP who is qualified under the MTP Act, and all other quacks under MTP Act. And why I am saying so? Answer is very simple. Read the definition of RMP under the MTP Act. The definition of RMP under MTP Act is a person who has qualification / experience in termination of pregnancy, essentially by being a gynecologist or whatever it is. Radiologist, pediatrician, neurologist, cardiologist, none of them fulfill the criteria of an RMP under the MTP Act. Now, those people who have never done MTP in their life, a pediatrician or somebody of the sort who has never done an MTP, doesn't understand about it, has not read this kind of a GR, is not going to approve for all these kinds of things. So typically what they do is they say, oh, we don't want to talk about it. We will say if the child is born alive, then we will do give treatment in NICU. Now it's a stupid thing to do. The way the law of the land stands is any human being who is born alive on this earth is supposed to have all the human rights, including right of survival. However, any human being who is not born alive, no such kind of right accrues. So it means the fetus does not have a right to live, irrespective of the mother's choice, but a newborn has a right to live, irrespective of the gestation. So the only way to correctly terminate the pregnancy beyond 24 weeks is to do feticide and terminate this pregnancy and get a dead baby on this particular earth so that there is no complication. Otherwise, it will be a great. And this is exactly what happened in my case. When this girl came to me at 26 weeks and she said that I want to terminate the pregnancy with Nikhil, Datar and at Cloud9 Hospital, I said that if I terminate by so-called board's opinion, and the board's opinion was what? Okay, you can terminate the pregnancy. If it's a live born, then do give NICU care. I said that my NICU might be able to send you home, okay, with an multiple congenital cardiac abnormalities, that fetus delivered at 26 weeks. I mean, because we are actually calling it as termination, but we are actually doing a preterm induction of labor and delivering them according to the norm, the way it is. Unfortunately, I said that 2 months later, with 20 to 30 lakhs of rupees of bill, they might send that particular child home with multiple congenital abnormalities. So, in my writ petition, I highlighted this particular point also, that this is what ideally should have been told by the medical board, which the medical board did not tell. So, the High Court asked the medical board to particularly opine on this particular thing. They told me to go and have a meeting with the permanent medical board. I had a meeting with the permanent medical board. Permanent medical board made a change in their report and they wrote that please do feticide, after which I did feticide at Cloud9 and terminated the pregnancy. So the correct way is to terminate the if you are calling it as an abortion, then it has to be by feticide and then doing the termination of pregnancy. Unfortunately, again coming back to the same thing, because of the lack of clarity on the definition of MTP in itself, we are having all these difficulties and problems. So this needs to be actually nipped at its bud, because only and only then the rest of the things will follow their normal consequences.
Dr. Nikhil, I just want to ask one thing. Like you said, the medical board will take that. So medical board has to take the decision for MTP and also they have to tell for the feticide.
Yeah.
They have, because so
that's what the GR
cannot
says.
proceed for the feticide part till we get informed the details. But
Madam,
there
if
is
you
no
read-
place as such.
If you read the GR, okay, if you read the GR. Now,
MTP
again,
Act also has given the authority to medical board to say yes or no for MTP only.
exactly, but
And
what is
they are
MTP?
not given the authority regarding the feticide part.
No, but that's
how
why.
they will-
What do you mean by MTP? That's what is the question. What do you mean by MTP? Are you meaning MTP means preterm induction of labor?
I think there are some unanswered questions. We may have to continue
Yeah,
on
I
another
think this
day
discussion
because we have
will
run
go
out of
on
time.
because
So that's why I have
also
filed.
my understanding, Dr. Datar, was that fetal reduction comes under the purview method of termination, right? So
Sorry?
I think this method of
Oh.
termination, how you terminate the pregnancy, is something that the medical board doesn't tell us, right? So
No, it
feticide.
should tell us. They are supposed
No,
to
it
tell
should
us,
tell
but
us.
they don't
No,
tell
but
us.
currently it is not there, right? So
No,
to
it
just
is
It's not
there.
there. Medical board we also have in our college also, but medical board says yes or no for MTP. They are
That's
not
it.
giving
Exactly.
any opinion for feticide. It is the
Absolutely.
gynecologist
That is
who have to
exactly
take
what
the
I
That's
want
what I'm
to
saying.
say.
That they should say.
Currently, we do not have the, doing feticide prior to that. I think we have to start discussion on another day because we are
So
already
yeah,
running
maybe
way out of
in second part we will continue this. I think
yeah,
it's
yeah.
already
But I just
time
like to
and,
make just one single point that obstetricians should not presume that just because the baby has an anomaly, the baby will be born dead. Majority of the babies after 20 weeks termination will actually be born alive and
Absolutely.
struggle to death,
Absolutely.
which is very unfortunate.
Absolutely.
And what is even worse is many of them are taken home and starved to death. Right?
100%
So I
true.
think feticide prior to termination is an absolute
Mandate.
terrible for the clinician.
Yes,
but
it
the
is there. Dr. Nikhil,
gentle
you are a
thing
part
done.
of our FOXY GCPR also, and even WHO now also recommends doing pre-MTP feticide.
Yes.
Everywhere in the world,
it has
any
been in the
termination after
recommendation for doing the
has to have
pre-MTP
feticide.
feticide now.
Yeah.
That is why, madam, when you were doing the GCPR, I insisted that this is
Yes.
quoted in our
Yeah,
GCPR.
so it is in the recommendation. That's why I was just sharing the slide actually. Someone told me to stop sharing. I'll just show you once to the
So,
audience. I just
we have to
wanted
wind up, Dr. Richa. Shall we
Yeah,
continue?
just one second. Just this is a most important part. See this this chart I have taken from WHO recent 2023 and our FOXY GCPR also. Dr. Nikhil also, you were also a part of our GCPR. So potassium chloride intracardiac, it is little difficult, but putting intraamniotic digoxin is in the recommendation, and lidocaine also, although they are less effective, but they are there in the recommendation. So who can do the pre-MTP feticide need not be the fetal medicine specialist, can be any obstetrician who can do the procedure, and doing intraamniotic, I think, does not require any much expertise. So it is there in the recommendations already. And one thing I want to highlight, after 24 weeks, if the medical board say yes for particular MTP, two obstetrician have to perform the MTP. So they have to take the call regarding the feticide part. So now I stop screen share. We are exceeding time. Maybe we can continue in next of the webinar.
Yes. Thank you
Yeah,
so much,
Dr.
Richa
Lavanya.
ma'am. Yeah, thank you so much, Richa ma'am. Thank you so much, Pratima ma'am. It was a wonderfully conducted webinar. Do we have any take-home messages? Very short, crisp, and concise only, please. From all our esteemed panelists. Any take-home messages, please?
I think we can start with Dr. Anthony.
Yes, please.
I think.
Thank you, Dr. Pratima. First of all, hats off, I think, to all the fetal medicine people, because not only is the knowledge of it exploding at such speed, there's so much of documentation and forms and regulations, and as Dr. Datar rightfully scared all of us, all the best to all of you. But as a treating surgeon, my take-home message, which I would like to share, that the more I know, actually, I should be brave enough to say I don't know anything about this, especially with coming with this upcoming field of yours. Because I think sometimes the confidence with which people are dictating the future course of events, it is scary. And it's a sobering thought. As the last line, I was born in 1969. I had a high erectile malformation, associated colonic atresia, spina bifida, I have neurogenic bladder, and I had neurogenic bowel. And I've become a pediatric surgeon. I am glad that I was born in 69 and not in 2024. Because current guidelines wouldn't have let me through. So basically, the humbling message I want to leave for all of us is that, yes, the knowledge is great, but we still don't know many things about life. Thank you.
Dr. Kuldeep?
I'd like to say that, no, I was going to lead, that's why I was apologizing. The message I'd like to give is that it's all teamwork, and we all have to work as a team. The fetal medicine, the sonologist, the genetic specialist, the pediatric surgeon, we all have to work as a team. And we have to make sure that it's not just focusing on one point, but all the points that need to be done. Thank you.
Thank you. Dr. Seetha?
Yeah, echoing Dr. Kuldeep's words in saying that we work as a team, so proper liaison with each one of them is important, and involve the patient as well in the entire decision that what exactly she wants at the end of the day to make, to counsel her accordingly. So yes, the proper liaison between different specialties. Thank you.
Dr. Datar? Chaitanya Datar. Sorry, there are two Datars. I'm sorry. Dr. Chaitanya Datar.
Essentially, now the era of overdiagnosis based on scans as well as from genetics, what we have come across. So proper counseling as regards to the anomaly, the reports, and the outcomes is very much necessary before we really, consider or counsel patients regards to discontinuation of pregnancy. So proper outcome counseling regarding outcomes are very much necessary, because we have these metabolic disorders which we can treat postnatally also. So even if a report comes out as an affected fetus, still we can counsel them as regards to the postnatal management that can be considered for these patients. So we always need to discuss both the options with all the cases.
Thank you. With that, we would, I think, come to a conclusion for what would look like part one of a webinar that would have gone on for another 2 hours had you given us time, Dr. Manjeet. So I thank you. I thank the enthusiastic.
Madam, can I give a last message?
Yes, Dr. Nikhil, your message, please.
So I just wanted.
Oh, I thought your message was over. Sorry, my apologies.
So there are nearly 27 abnormalities in the MTP Act itself. First of all, okay? And that is why I have challenged the MTP Act, amended MTP Act, again in the Supreme Court. So probably that might solve most of the problems in which these issues will get solved. Number one. Secondly, I want to tell you with folded hands that follow MTP Act to its T. Do not go beyond the purview of the MTP Act, because going beyond the purview of the MTP Act is exposing yourself to the criminal charges under Section 312 of the Indian Penal Code. So We are all superheroes, but be under the umbrella of the act and be superheroes. Don't try to show your over smartness by going out of the purview. Which day will come and it will cause trouble to you? You cannot say that. You cannot predict that. So be superheroes, but within the umbrella of the MTP Act.
Okay, so thank you. Wonderful discussion. Thank you all the panelists. Wonderful. And thank you, Dr. Pratima, for wonderful cases. Once again, thank you, Dr. Nikhil, Dr. Kuldeep Singh, Dr. Seetha, Dr. Anthony, and Dr. Chaitanya. Wonderful inputs.
Thank you.
And thank you, organizers. Now over to the conveners for vote of thanks. Thank you so much.
Thank you so much, ma'am.
Thank you so much, Richa ma'am and Pratima ma'am. On the behalf of ISPAT, first of all, I'd like to extend my most sincere thanks to our President, Dr. Saurabh sir, and our Secretary, Dr. Manjeet ma'am, for making today's event a resounding success. With your blessings, we were able to make this event so successful. Thank you for being the catalyst, ma'am, and thank you for keeping both me and Dr. Bhavya so stimulated to do our best. And I extend a really hearty vote of thanks to our moderators, both Dr. Pratima ma'am and Dr. Richa madam, and our panelists who spared their time from their busy schedule to grace the occasion and sharing their opinions today. A heartfelt thank to all the guests who have logged in today's webinar. It was so successful, and this is surely going to encourage us in our future events. I'm immensely thankful to Dr. Bhavya for her efforts and towards this webinar. She was wonderful to work with. And a special mention for the people who are working behind the scene, our technical team, clarinet team, and Sangeeta. Are you there? Sangeeta and Rupsa both. Thank you so much. Thank you. Thank you, moderators, panelists, and thank you for the lovely audience that you were. Thank you. It was a very nice interactive discussion.
So thank you so much, everyone, for extending us the opportunity to host the session. So with all your permission, we are concluding the session over here and looking forward to host you again.
Good night and have a lovely weekend, everybody.
Good night.
Thank you. Good night.
Bye-bye.